While deaths from opioid overdoses have dramatically declined in the past few years, the crisis remains, claiming the lives of thousands of teens and young adults each year. Mental health concerns among youth are an important contributor to opioid use, yet parents often struggle with their own mental health challenges as they raise middle schoolers. Welcome to Inside Alvarez Business, a podcast dedicated to bringing you the stories behind the research. I'm your host, Jonathan Halbesleven, Dean of the Carlos Alvarez College of Business at the University of Texas at San Antonio. This season, we're focusing on the business of healthcare, sharing the stories of our faculty, their research, and what led them into this area. This month's episode features the work of David Beheshti and Qinyou Hu, both assistant professors of economics in the Carlos Alvarez College of Business. David's research looks at the use and abuse of drugs and the impact it has on labor markets, while Qinyou explores the interactions between health and education and the roles played by schools, family, and the community. Listen to hear how their research insights help explain economic forces shaping health, education, and policy, and how those insights can inform better solutions for our society. Well, welcome back to another episode of Inside Alvarez Business. I'm delighted to have two guests with me for this particular episode. So David and Qinyou, welcome to Inside Alvarez Business. I'm really looking forward to hearing the stories behind your research.
Yeah, thanks for having us.
All right. So I'm always interested in how people kind of start down the road of an academic career. I don't know about you, but I've yet to meet somebody who, when they were a kid, said, "I'm going to be a professor when I grow up." That's my dream. That doesn't kind of rank up there with firefighter and some of the other occupations. So I'm curious, what was your path? And why don't we start with you, Qinyou?
For me, so my story is actually my father has been a middle school principal.
Okay.
And so he transitioned from a middle school teacher to a middle school principal for like 3 or 4 years.
Mm-hmm.
And then my mother is she has been a nurse in the cardiology department for more than 20 years, and she just retired last year. And then so this the first exposure coming from the family kind of motivates me all these interesting questions related to this education and health, these two aspects.
Okay.
And then to tell you the truth, when I went to college, I have never thought about becoming a professor.
Right.
During the college, I tried different type of internships.
Mm-hmm.
So I had this experience in banking industry and some other volunteer in middle schools, something. But I feel this is not my passion, and I think the whole process, everyday life, is so boring and tedious, and then that doesn't make me feel alive.
Mm-hmm.
And then I had the chance to come to the United States for my graduate study, and then I remember it's one of the math course. So I still take the econ major, econ master program at Duke, and then one of the real analysis course. The teacher really inspired me and then encouraged me to kind of thinking about the potential of this academia type of route. And then I also had a chance to get exposed to conducting research with professor, and then I tried to really experience the whole trajectory, the process of working with data, process of publishing, process of seeing the paper out. And then so this whole process, I feel that's really the one that I enjoy, and all these ups and downs make me feel alive. So that's kind of then naturally I went up and continued the PhD trajectory, and then come to the UTSA. So.
Oh, very good. And it sounds like a very familiar story in the sense that usually somebody has to encourage you to think about it, and then getting a little bit of experience with the research kind of helps gives you a picture of what it's going to be like. So.
Yeah.
So David, how about you? What was your path?
Yeah, so it sounds like Qinyou had a lot of good reasons for going into academia, and I was the opposite.
Okay.
I just really liked school when I was an undergrad.
Yeah.
I had no idea what a PhD was. I had no idea what being a professor was. I thought professors were just teachers. But I liked school, thought, PhD is just going to be more school. Turns out that's wrong. I had no real sense of the whole research aspect of things. But I wanted to do more school, applied for some PhDs, and then, for the first year, that was approximately right, just doing more classes and stuff.
Yeah, really.
But then you make this transition into research, and that was just totally out of left field for me. Fortunately, it all worked out and I ended up enjoying it. But I always tell my students who ask about, potential PhDs, like, make sure you know why you're going. It's not just more school. You're really doing a apprenticeship in research. And, worked out for me, but was probably not a wise decision, ex ante.
Okay. Very good. Very good. Kind of related to that, it's sort of related to the path part, but we're going to talk a little bit more about some of your research here in a second. Before we do that, I'm curious, both of you have studied elements of kind of health, or, you already kind of mentioned, about the family and, understand it, like being kind of part of a family. You got interested in some of those topics, but could you kind of, we'll start with you, David, talk about like what inspired you to study, like in your case, some of the issues with drugs.
Yeah, so a lot of the drug abuse stuff came from just kind of the environment that I was in the time in graduate school.
Okay.
So this was, I started graduate school in 2014. This was around the time when a lot of states were legalizing recreational or medical marijuana.
Yeah.
And so there was a lot of kind of policy interest in what are the effects of this? What happens when you legalize this drug that's been federally illegal for, a very long time. I was interested in that as well. I started becoming interested in how does one state legalizing marijuana affect neighboring states?
Yeah.
The reason I had that thought was because there was some states suing other states for legalizing marijuana, saying, hey, this is negatively affecting us, you can't do it. Those cases ended up going, I think, all the way up to the Supreme Court, although I don't think they ever actually made a decision on that. But as I was looking at this, there was a lot of interest at the time about, does medical marijuana have a potential to reduce opioid dependence? If you can get people on something that is less dangerous, maybe that's a good thing. That led me to start learning more about the opioid crisis and how big of a deal that was. And so I kind of naturally transitioned into that direction, just because it seemed, the marijuana stuff was interesting, but the opioid crisis seemed just like much more important from a public policy perspective and from kind of a human cost perspective.
Very good. Qinyou, do you want to kind of expand on maybe more specific, like things that inspired you to study some of the topics that you're studying?
Yeah, I think the main reason still go back to my very beginning, like the first exposure coming from my family background. And then I think for me, I'm also naturally become interested in topics that way closer to my personal life or everything happening like closer to me. So that's why my research topics are more concentrated on the things happening to the kids, to the students, to the family, and all environments. And yeah.
Okay. Very good. Qinyou, if it's okay, we're going to stick with you and start talking a little bit more about your research. So I wanted to ask you in particular about some of your recent work on mental health. So as a dad of a middle schooler, I took particular interest in your work on this idea of the middle school blues. And David, you might want to listen up. I know we didn't mention it yet, but congratulations. It's a miracle he's here. He has a 2-week-old newborn. But eventually middle school's coming for you too. So can you talk a little bit about what middle school blues is?
Yeah, so that's actually one of my favorite paper.
Okay.
So the middle school blue is a phenomenon that's already detected in psychology field, but it's very weird that in economics we still pay very little attention to this phenomenon. And basically, that phenomenon, what it says is, if you try to plot the relationship between like parents, adults, like mental health status, and along with the age, so what you can see is this V-shape type of the figure, and then it's around the middle school and when their kids are during the middle school time, then you will see this adult, they experience the lowest level of the mental health status.
And this is the parents.
Yes,
Yeah.
yes. And then so that's basically the idea of like the middle school blue. And then so I think the psychology paper, they what they find is coming from a set of like population, and then my paper tries to first replicate this phenomenon using like a larger sample, and then still this phenomenon holds in that like way larger sample compared to that. Yes.
Okay, very good. So one of the kind of key things in your paper is you found an intervention that seems to help somewhat with this. Could you talk a little bit about what's that like, maybe from like the parents' perspective, what they go through?
Yeah, so the intervention is it's a parental involvement program. So basically what the intervention did was we designed a series of like parent-child activities. So it seemed like you read books together with your kids or you watch movies together with your kids. And then we had this, so the intervention lasted for a semester, so basically like a 4 months. And then each month you were encouraged to engage with your kids like through this particular activities.
Okay.
And then the other feature of this activities is like it's not like with random topics. Each activity is everything is about empathy. So we have this particular topic, particular thing, and then the goal is kind of cultivating both the parents and also their kids' empathy skills. So empathy is more of now you really start to understand from the other's perspective, and then that's how we think of like, because there's also another type of theory established in psychology that empathy can be learned, especially when you try to see, and then when you there's like a simulation type of theory, and then so you can learn from observing like others' behavior, and then you can also try to through the conversation you can understand what is in their mind. So then through this type of interactions between parents and the kids, so that's why we kind of design all those activities into the intervention, and then try to improve both the parents and the children's empathy level. So
Okay. So you're trying to improve the empathy level, and then how do you capture mental health?
So the mental health is we just follow like usual type of method, and then the way that we try to measure a mental health level is through like asking a series of questions in the survey questionnaire,
Okay.
and then try to elicit their well-being level that they experienced. So that's kind of the way that we try mental health. And I think in addition to this, just eliciting the measures using surveys, we also have some concrete like behaviors. So in the through this mice control trial experiment, we also collected data about the kids' actual test scores. So these are one of the education outcomes, and then we also have measures about like the interactions, like the real activities going on between the parents and the children. And then we also have records on the bullying behavior. So that's more of a like real action type of measure.
And those improved as well?
Yes.
Oh, wow. Okay. So if we kind of put this together, what I'm hearing you say is spending time with your child helps increase your empathy, which I guess makes sense, right? You get to kind of know who they are, what the way they're thinking, and then that improves some of the mental health outcomes, sounds like, for the child and the parent.
Yes. And then I think also the interesting story is that I think through that paper, we can also see that there's this natural interaction between education and health. So it's like when we improve health outcomes, we can also see this cross productivity happening between health and education. And then there's also interesting spillover from the kids to the parents.
Yeah.
So the parents improve their mental health. One thing so we also try to understand like why that's the case. So the first thing is because we teach the parents like these specific type of activities they can engage with their kids. So in the sense that they improve their parenting skill. And then the second aspect is because the kids, they also improve their mental health. So there's this spillover coming from the kids improvement of the mental health to the parents.
Yeah.
So these are the two things that I think is like super interesting that we find.
Okay. Very good. So I guess tonight I need to go home and tell my kid to quit playing Minecraft. Make him talk to me instead. And then I'll feel better.
Yeah.
So that's good. Okay.
I can send you the scripts of the reading tasks and the movie.
Perfect. Perfect. Yeah. Send me some ideas for movies. Otherwise, I know it's going to be like Harry Potter again. So perfect. All right. Well, David, kind of turning things over to you for a little bit. You've been studying some interesting issues for a number of years related to drug use and abuse that you kind of talked about a little bit earlier. What would you say some of the kind of main takeaways are from your work?
So I think there are a few. The main project, or I guess a couple of projects, the first thing that I started working on was looking at kind of the recent, I guess it's not recent anymore, but the transition between prescription drug use and abuse towards street drugs. So around 2010, that's where we really saw this transition from people misusing prescription painkillers to people misusing drugs like heroin, and then more recently fentanyl. One thing in that first paper that I looked at was, there's a lot of reasons why you might think using heroin is worse than using prescription painkillers. Because, you're not getting it from a pharmacy. Maybe it's stronger than the drugs that you were taking, other things. One particular issue there, though, is that for the most part, people who are misusing prescription painkillers, they're taking the pills. Okay, they might snort them, but for the most part, they're just swallowing the pills, maybe chewing them up first if it's
Mhm.
an extended release pill. But with heroin, people are much more likely to be injecting the
Yeah.
drug.
Yeah.
So one of the things that we looked at and saw there is that in this transition from prescription drugs to heroin, we start seeing more contagious bloodborne diseases spreading. So that was one kind of, you know, we think a lot of the transition from prescription drugs to heroin and fentanyl is in some sense policy driven, right? You reduce the accessibility of prescription painkillers. People are already addicted to them, so they go out and find the best substitute they can, and that's, heroin or fentanyl. And that there are things to be worried about other than just, the change in the substance itself. So we see, changes in these contagious diseases like hepatitis C is the big one that we look at there. As far as other takeaways, another project that I have looking at this that I worked on a lot in grad school was looking at the relationship between prescription painkiller use and abuse and labor market conditions. So if you look at a map of the United States, the places that have lots of problems with drug abuse, potentially not surprisingly, tend to also be places that don't have particularly great labor markets. So a lot of unemployment, low labor force participation, things like that. And you could imagine this being because drug abuse is causing bad labor market conditions. Okay. You could also imagine it being the case that the economy's bad. I don't have a job. I'm depressed. Things are just bad. And so I turn to drugs as a kind of coping mechanism. And it's really hard to kind of disentangle that. So what we end up doing is trying to find, without getting too much into the weeds, trying to find variation in drug availability and see how that changes labor market outcomes. And we found something that was surprising. What I expected to find, we ended up finding a situation where basically a certain type of opioid became much less accessible. In certain areas of the country, we're much more reliant on that particular type of opioid. What I expected to see was worse labor market conditions after this policy change in those places. The reason I thought that is because there's some prior work looking at what happens when a particular type of NSAID was taken off the market for people with arthritis. So this was COX-2 inhibitors, Vioxx was the drug. And what they found is when you took away this medicine that people were kind of relying on to get through the day, they were absent from work more often. They were more likely to quit their job. They just weren't able to do what they needed to do because, their pain wasn't treated.
Yeah, it was helping to manage the pain.
Exactly. I thought we were going to see a similar thing, but it turned out we found pretty much the exact opposite. We found that basically fewer people were getting hooked on this drug and preventing kind of these downward spirals that led to bad labor market outcomes. So we ended up actually seeing movement, again, in the opposite direction of what we expected, but reducing the amount of prescription painkillers out there ended up leading to positive labor market effects, which was surprising to me. I don't know if that was surprising to other people, but I thought we were going to see the opposite.
Yeah. One of the things as I was looking through those two studies in particular, kind of struck me is how often you kind of found what I think most people would think of as unintended consequences of the work, right? So, for example, when in the first study you talked about when the opioids were reformulated to be less addictive, then people turn to heroin, and then we start to see increases in hepatitis B and C. So it's like, try to fix one thing and you get something else. Yeah. Or even in the case, I know you said the labor market changes were not what you had expected, but what's kind of interesting to me also is the drug becomes less available, the labor market improves, but you also found that there were more drug-related deaths and higher arrests.
Well, we saw higher arrests. That was the main thing. I mean, these were arrests that you would expect to be kind of related to drugs. And so, it seems like there's no real free lunch. You take away these things that people have become dependent on. And there's kind of a dynamic effect that I think is important in that if you take away these drugs that are really addicting, potentially you might have short-run pain as a result of that. You have these increases in arrests, you have people switching to more dangerous substances. I think the hope is that in the long run, if you can prevent people from just going down this path to begin with, then maybe, it could be the case that in the short run, these policies are causing a lot of negative effects, but in the long run, maybe things get better. I think there might be some evidence to suggest that that's true. But anytime you're changing, I think what you brought up with Oxycontin. So Oxycontin was the most popular prescription painkiller among people who were misusing prescription drugs. The reason for that was because it was an extended release pill. It had up to 80 milligrams of oxycodone in it, which is the active ingredient, which is an insane amount, but it would release that drug slowly over the course of, 10, 12 hours.
Okay.
But if you just chewed it up, that broke down the extended release mechanism. And so you get the whole dose at
Quite a
once. And
workaround.
this was very well known. But then the manufacturers, I think to their credit, recognized this was a problem. They did what you said. They reformulated it to where chewing the drug didn't release or didn't break down the extended release anymore. And so, you can find threads on the internet of like drug user forums where people are saying, hey, where can I get the old Oxycontin? People are looking for it.
Yeah.
And then you see these conversations of people saying, we're just switching to heroin. And you see it in the data too. You see heroin death spiking right at that time. Fortunately, those have come down, but unfortunately, we just seen skyrocketing fentanyl deaths. So yeah, I think what the future looks like is, I think, uncertain. I think the hope is that a lot of the work that's been done to prevent people from getting addicted to prescriptions in the first place will pay off in the long run.
Yeah.
But I think something that's alarming is more and more you're seeing people skip the prescription stage altogether.
Yeah.
So it used to be the case that almost everyone who was addicted to heroin started by using prescriptions. That's no longer the case. People are taking fentanyl without ever having used a prescription opioid.
Oh,
And so I think, in a way that's kind of depressing, the ability of policy on the medical side to do anything about where the opioid crisis is now, I'm a bit pessimistic about, honestly, because, it's not the prescriptions that are getting people hooked now. They're going right to the hard stuff.
Yeah. Well, and it really does feel like it's really all about trade-offs with any of these types of things. So,
Yeah.
I mean, one of your other papers, for example, had found that because of the increase in opioid availability for prescriptions, like people are actually able to get the surgeries that they otherwise wouldn't have really been able to do because they couldn't manage the pain post-surgery. And so, I mean, obviously it helps those people to be able to get the surgeries.
Yeah.
But then, of course, there's the potential issues of abuse, or in this case now, the prescription drugs maybe aren't as much of the problem. So it becomes even harder to figure out. It's like sort of like that whack-a-mole game, when you go to an old arcade, I guess, if those still exist. But, you kind of hit one mole and another one pops up. And so it
I
makes
think
it
it's
that much trickier.
really hard to figure out what the best kind of policies are surrounding opioid availability, because these drugs exist for a reason. If you're in a lot of pain, they're going to do better than pretty much anything else, especially for acute pain, post-surgical pain. But they come with all these potential negatives, and I think figuring out kind of where to strike the right balance is definitely tricky.
Yeah. So I'm curious with both of you, because a lot of economics research, there's the potential to lead to policy of some sort, right? Not everything, but in many cases. If you could, based on the work that you've done, whether it's the studies we've talked about, or it could be something completely different, that's okay too. If you could kind of wave a wand and a law gets passed or a policy gets put in place that you think would really make a difference, what would that look like?
Yeah, I think it's honestly really hard to say, especially with the opioid stuff, because, if you look at the history, at least the relatively recent history in the US, in the 80s, late 70s, early 90s, you go to the hospital, you're in severe pain. They're so afraid of opioid addiction at that time that they're not prescribing anything.
Yeah.
And so you can read all these accounts. You can read medical literature from the time with doctors saying, hey, this is probably not the best way to practice medicine. We're letting people suffer, potentially needlessly. We should be more aggressive in treating their pain. Then we went the complete opposite direction to where now, not now, but in, maybe 2002, you go to the doctor, you say, hey, my lower back hurts, and here's a lifetime supply of Oxycontin, which, comes with its own problem. And then over the last 10 years, we've gone back towards where we started. But I think there's, real issues with that, in that if you're in a lot of pain, these drugs do help. And so trying to figure out, again, as you said, it's all about trade-offs, and it's hard to figure out where exactly the right kind of the sweet spot is.
Yeah.
I think some potentially low-hanging fruit, and this is already something that a lot of states have done, is to try to make prescriptions for, high-potency opioids just shorter at the beginning. So, for example, I had my wisdom teeth out when I was, I think, a senior in high school, and I got a 30-day supply of Demerol. I'm glad that I had it, but I didn't need 30 days.
Yeah.
I think a 2-day supply would have been much more appropriate to, managing the pain while I was in it,
Mhm.
but not, running the risk of having these pills around where I could get addicted, someone could steal them, I could sell them,
Yeah.
all these potential negative things. But, the opposite is sometimes true now. So I think this is an interesting kind of just anecdote about how prescribing patterns have changed over time. I broke my hand when I was in high school playing football.
Mhm.
Similar to when I got my wisdom teeth out, I got a 30-day supply of opioids
Okay.
for a broken hand. I broke my hand about 3 years ago, and I'm sitting there in urgent care. My hand's the size of a softball,
Mm.
and they ask if it hurts. I'm like, yes, of course it hurts. Like,
Yeah.
okay, we'll give you something for that. And they come in with 2 ibuprofen.
Oh, goodness.
And so that's what I get. And I say, hey, can I get something a little bit stronger? And they're like, oh no, sorry, we can't do that. And this is, I don't know, 8 years apart, just how
Right.
much things have changed. And I think it, would have been appropriate for a small, short opioid script
Mhm.
for, something like a broken bone. And I think it's just, really a struggle to find out, what's the right pain management versus risk of addiction and
Mhm.
negative consequences.
Yeah. Yeah. Very good. Qinyou, how about you? Is there a policy you can think of that you'd put in place based on the work that you've done?
Yeah, so my take is because a lot of my papers are around this topic of trying to improve the adolescent health well-being.
Mhm.
So I think one takeaway is that we should really also involve the parents' side, and we should also consider this additional factor. And a lot of the health inequality or health disparities, they actually started beyond just we thought like medical type of industry or healthcare industry. It's
Mhm.
also about this social environments like families, schools, and communities. So I think trying to improve the one of the factors that's like through the family perspective can be a potential cue. And I think the other thing that I'm also find through one of my papers that usually when we consider about someone making decision, we tend to consider like this is like individual decision, but
Mhm.
usually it's not the case. It's usually because they are affected by a lot of social factors. Because, for example, there are like peer effects, very common among adolescents, and
Mhm.
like maybe they get addicted to something is because they feel it's so cool, like they try to follow what other kids are doing.
Yeah.
So then I think the other thing is we can also look into the school side and then try to capture this type of friendship network and then try to target potential like head of the social network among the kids and then starting from that individual and then yeah, that will be also another way to think of a potential like effective policy and then can be cost effective because we don't need to like include everyone, but we can just target a particular like head of the
Yeah.
yeah.
I was just thinking about as you were describing that too. Those little nuances and complications even in that. I mean, so you've got an intervention, for example, that you showed really works well. But if you've got a parent that has to, because of the economy, for example, it's not that great, and they have to work 2 jobs, inflation stuff. They have to work 2 jobs, and they don't have as much time to spend with the child. You've got all these other kind of factors that kind of creep in there that make it all the more difficult, and potentially for the folks that need it most, that need that intervention the most. So, would you say the intervention is simple enough that you can get around some of that, or would that really be a challenge?
Yeah, I think definitely for this type of situation, if we so I think how I think of this problem is that ultimately the students or the children's well-being can be a product of a lot of factors.
Mm-hmm.
So the factors include schools, communities, and the families.
Mm-hmm.
So and when one of the factor is not that it's hard to work for some of the population, then we can consider increasing the input of the other factors.
Okay.
So say like the schools side or the community side.
Mm.
But and then the other thing is also these factors can be like affected each other. So say like if the family part is really like difficult to deal with for some particular population, then we can try to see what is going on in the classroom side and then what is going on in this inside the school and then so that's another thing that I find in another paper that the friendship also matters and then we can see these interactions going on between like what happened in the within the family and what happens in the classroom. So that's also I think the way that I try to understand why we see this intersection.
Okay, very good. So what's up next for both of you? David, what's the next project that you've been thinking about, or maybe you've even gotten started with?
Yeah, so I've got a couple things that I'm excited about that are in like really early stages.
Mhm.
One of which is me and another guy that I was friends with in grad school. We put together a data set, basically the history of physicians training.
Okay.
So it's been publicly available for a long time where physicians went to medical school.
Mhm.
But if you talk to a lot of doctors about kind of where they learned actually how to practice medicine, more commonly you'll hear that it's during their residency or during their
Yeah.
fellowship. And that hasn't really been studied to my knowledge in economics, looking
Interesting.
at the effect of residency training
Mhm.
on behavior. So we've put together that data. So now for every physician in the United States, we know where they did their medical school, where they did their residency, if they did a fellowship, where they did it.
Mhm.
And then we can look at kind of their practice styles now. What has been, I think, most interesting so far, again, we're in the early stages of figuring out what to do with this data, is we thought we were going to see just crazy strong effects everywhere
Mhm.
based on the conversations that we had with physicians. What's been, I think, much more interesting is so far we have yet to find strong impacts of where you did your residency on anything.
Okay.
One of the first ideas that we had was looking at if you did your residency in a location where there was, lots of where opioid prescribing was more common,
Mhm.
are you more likely to prescribe opioids later on in your career? The answer to that is basically no.
Oh, okay.
We've looked at just general spending.
Mhm.
So if you go, something about the U.S. If you look at a map again, we spend wildly different amounts of money per patient in different areas of the country.
Okay.
We were curious if that had to do with, your residency. So if you do
Mhm.
your residency in a place where you're spending lots per patient, do you then spend lots per patient later in your career? All of these I should caveat with where you do your residency impacts where you go.
Oh,
So
right, where
people
you're winding
tend
up.
to, you're disproportionately likely to practice medicine in the location where you did your residency
Mhm.
later in your career.
Yeah.
And so if you do your residency in a location that's high spending, you're in a high spending region.
Right.
But if we look at people who move away from that region, they pretty much look like the people where they moved to. So they don't seem to be carrying a lot of their residency behaviors with them.
Okay.
And so we're still trying to figure out, what's the right setting to look at this? Or is the story just residency matters a whole lot less than we thought it did?
Yeah. Okay. Very good. That sounds like some interesting stuff then. Qinyou, how about you? What are you working on?
So I think I have like two big directions. The first direction is still like expanding around this intervention,
Mhm.
and it's so interesting because this directly go back to the point that you raised about some cases the family side may not work for the particular population, right? So then we are so lucky that there are like some people reaching out to us and then trying to invite us to collaborate and then conduct a similar type of intervention, but in the context and also some Latin American countries,
Okay.
including like Colombia and Ecuador, something. So these are
Okay.
so I'm super excited because these are completely like different contexts compared to the one that I implemented the experiment.
Yeah.
And they also told me that because the intervention that we did rely some sort of like high tech type of thing, because what we did is we designed a mobile app.
Okay.
But then there's some digital literacy happening in the Chilean and the Colombian and these contexts that they invited us to implement the intervention. So I'm very excited about this, and now we are at the stage of trying to incorporate and adapt some of the elements and then to better suit these type of contexts. And then the other thing is I also very curious about whether this type of intervention can have external validity. So we show that works in the context that I implemented, but who knows about whether it can also apply to these like completely different type of contexts.
Yeah.
So that's one direction. And the other direction is because I feel like my research is everything about the intersect among like education, health, and the family. So this direction is more about. So now I try also to investigate into this healthcare industry, and what I'm trying to answer the question is whether these type of family signals can also affect some of the physician behavior. So we studied this in the context of ADHD diagnosis and the prescription, and then the question is, so it's in the context of Taiwan, and then so they have this admin like the very large scale type of data. And then basically we can track all the households, all the physicians, all the histories, and all the prescription records, diagnosis records. And then so we really want to see like when there's a new drug coming out. And then, for example, if the physician already had experience of treating some of the siblings of the new patient, whether that will affect like how they prescribe the specific drug, whether they will still follow this old drug prescription style, or they will try to prescribe, like try to experiment what will happen using this new drug. So this is kind of another direction that I'm curious about, like whether this family signal can also affect this healthcare industry and then particular physician decision.
Very good. Well, some good work coming out from both of you here in the future. So I do have one last question for you. You know, I understand you must do some other things besides your research. I hope you do some other things besides your research. So I'm curious, outside your work for the Carlos Alvarez College of Business, what are some of the things that interest you? How about we start with you, Qinyou?
So I actually a big fan of high intensity interval training.
Oh, okay.
So I basically usually in my weekends I would just immerse myself in the gym.
Okay.
And I'm also planning to register this High Rocks competition.
Okay, yeah.
But so that's why this breakfast I had protein shake.
Ah.
And I just adapt to that. And then I also when I try to like calm myself down, I will just playing with Lego. So I'm a big fan of the collection of Lego.
Okay.
So it's how I spend my time outside of that.
Very good. Very good. We have something of a connection, not on the training part, obviously. But if I were to spend more time with that middle schooler, it probably would be building Legos. So
the other thing is I also like hiking.
Oh,
So that's why I was like so excited about San Antonio, because Houston, I moved from Houston, and Houston is so flat.
yeah.
So
Yeah, not exactly known for its hiking. Yeah. Okay. Very good. David, how about you?
Yeah, so I've got a couple of things. Starting about 5 years ago, I started training Brazilian Jiu-Jitsu.
Oh, okay.
So I train, 5-6 days a week.
Uh-huh.
I compete several times a year.
Wow. Okay.
Yeah, so I've been doing that. Just got my purple belt, if anybody out there knows what that means. But yeah, so spend a lot of time doing that. And then I've also been learning some music. So I started playing piano about a year and a half ago.
Oh,
And
wow.
recently picked up lessons and then really enjoyed that. So I got a guitar too and doing guitar lessons as well.
My
So
goodness.
lots of music stuff. And then, fighting with other people.
Yeah. Sorry, I know this is supposed to be a podcast about research, but I'm curious because there's actually a Brazilian jiu-jitsu place right by my house. And I've always kind of wondered, I mean, I know how a Brazilian steakhouse is different from a steakhouse, but how is Brazilian jiu-jitsu different from other forms of martial arts?
Yeah, so jiu-jitsu is primarily grappling based.
Okay.
So if you think of something like, karate or taekwondo or something, or boxing,
Mhm.
you're hitting each other,
Yeah.
which in fighting is great. One of the downsides of that though is you can't train full intensity all the time.
Oh.
So if we hit each other in the face over and over again, we're going to have problems.
Yeah, you're
So
going to
we-
need some of those opioids.
Exactly. Exactly. One of the advantages to grappling is you can train full intensity every day.
Okay.
You're not hitting each other. You're trying to take each other down. You're
Mhm.
putting each other in submissions. And, I think if you look at kind of modern mixed martial arts, if you watch that, grappling is a huge component of
Okay.
that. And a lot of the most dominant fighters have a grappling background, either in wrestling or in jiu-jitsu.
Yeah.
And yeah, a lot of fun.
Very cool. Well, you two do really have a lot going on. I'm just happy if I can make it through the day most of the time. So this is terrific. So, well, Qinyou and David, it has been such a joy talking with you. I'm so glad to know that we have amazing researchers like you here in the Carlos Alvarez College of Business tackling these particularly important health-related issues that impact our society so broadly. So thank you for being here today. And more importantly, thank you for the great work that you're doing to improve the health of everyone. Thank you.
thank
Thanks.
you.
Thank you for listening to the Inside Alvarez Business Podcast. Special thanks to our producer, Brittany Johnson, and for the support of Wendy Frost and Melissa Lackey to help make this podcast possible. Stay connected with the Carlos Alvarez College of Business at the University of Texas in San Antonio to learn more about how we are empowering the next generation of business thinkers and conducting groundbreaking research to ensure their success. Follow us on social media or visit us online at business.utsa.edu. Until next time, I'm Jonathan Halbesleben. Thank you for listening.